11th session, please. And so I'm pleased to introduce Dr. Nazli Disman from Yale University at the Medical Center at New Haven. And she will talk about the modulating gut microbiome to influence outcome with IU treatments.
Thanks, Dr. Negre. Good afternoon, everyone. I would first like to thank KCA for bringing all of us to this beautiful city and amazing content, and for giving me the opportunity to talk about this emerging topic. The learning objectives of this presentation are to understand the interaction between the gut microbiome and immune system, and recognize gut microbiome-directed strategies with potential for clinically meaningful improvement for our patients. Gut microbiome interacts with the immune system in many different ways, including the translocation of microorganisms or their metabolites into bloodstream, molecular mimicry, and many others. But when it comes to the clinical implications of this interaction, the crosstalk between the microbiome and cancer becomes more complex. Gut microbiome is impacted by the location of a patient, diet, lifestyle, occupation, use of prebiotics or probiotics, concomitant medications, perhaps most importantly, antibiotics and anti-cancer treatments. And all these characteristics shape an individual's outcomes with a specific treatment. There are several gut microbiome-directed strategies are being tested in clinical setting that we're going to discuss today. Fecal microbiota transplantation is an emerging concept in this space. In this study by Baruch and colleagues, 10 patients with melanoma who previously had disease progression while on immunotherapies were enrolled. Patients received fecal microbiota transplantation for 2 exceptional responders at baseline through colonoscopy, followed by oral capsules every 14 days. The enrolled patients included those who had intrinsic or acquired resistance, and a pre-FMT protocol with antibiotics and laxatives were also used. The results of the study showed 3 objective responses out of 5 patients who received FMT from donor number 1, versus no objective responses to FMT from donor number 2. The differences in different 2 groups could be due to several different things, but perhaps most importantly due to the difference in the FMT composition, or the success of FMT engraftment, or simply sample size and potential differences in patient and disease characteristics. Another FMT study had a similar design. 15 patients with melanoma who previously had disease progression on immunotherapies were enrolled and administered exceptional responder FMT from 7 donors. In this study, FMT was administered at baseline only 1 time and was not repeated. Colonoscopy was used, but the pre-FMT protocol was not used. The objective response rate was 20%, and an additional 20% of patients had stable disease surpassing 12 months. When we look at the FMT engraftment in this study, we see homogeneous FMT implantation in patients who responded to treatment, while a heterogeneous FMT implantation in patients who did not respond to treatment. Overall, it appears that successful FMT implantation is associated with improved outcomes. However, there are methodologic differences between studies that we need to take into account while we're planning the later phase studies with FMT. For example, whether to enroll patients with treatment-naive disease or in post-IO setting, or how to obtain the FMT from healthy donors or exceptional responders. And also the FMT administration methodology is important, whether to do it once or multiple times, whether to use a pre-FMT protocol or use a colonoscopy or use oral capsules. FMT comes with certain challenges associated with manufacturability, cost, and social acceptance. And a potential strategy that could circumvent these challenges is live bacterial products. Our group studies CBM588, which is a strain of Clostridium butyricum, in patients with metastatic renal cell carcinoma receiving nivolumab, ipilimumab in first line. We found strong translational evidence suggesting an enhancement in systemic immune response in patients who received nivo-ipi CBM588 compared to those who received nivo-ipi. And although limited by the sample size, we have seen a notable increase in response rate and progression-free survival with the use of CBM588. Another live bacterial product is MRX-0518. It is a lyophilized formulation of Enterococcus gallinarum. It was tested in a small sample size study in renal cell carcinoma patients who previously received immunotherapy and had disease progression on it, and it was administered with pembrolizumab. In this study, as you could see, there were some deep and durable responses. Multi-strain minimalistic ecosystems have also been developed using bacterial species that were found to be associated with immune response. An example is VE800. This compound was administered with nivolumab to patients with different metastatic cancers in later lines of treatment. However, this study was terminated early due to the lack of responses to treatment, although the compound appeared to be safe. Prebiotics are also being studied. Camu camu is an Amazonian berry that is being studied in Canada right now. The camu camu and its active compound, castellogen, increase the alpha diversity in gut microbiome and the abundances of Ruminococcus species, both of which have been shown to be associated with improved outcomes with immunotherapies in different cancer types so far. In preclinical studies, prevention of tumor progression was also seen with the administration of camu camu and anti-PD-1. Investigators also discovered a link between diet, gut microbiome, and outcomes with immunotherapy. In this retrospective study of melanoma patients, sufficient fiber intake was associated with better survival outcomes. And in preclinical studies, the administration of high-fiber diet with anti-PD-1 treatment helped overcome the resistance to immunotherapies. There are several investigations ongoing globally using microbiome-directed strategies. For example, Dr. McQuaid's team at MD Anderson enrolling patients with metastatic renal cell carcinoma in their randomized study looking at high-fiber diet versus standard diet. CBM588 in combination with nivolumab and cabozantinib was tested at City of Hope, and the results of the study is going to be an oral presentation at ASCO. Camu camu is being tested in patients with melanoma and non-small cell lung cancer right now in Canada, and a new study will be launched at City of Hope testing camu camu in combination with nivolumab and ipilimumab. And a healthy donor FMT study is ongoing actually in renal cell carcinoma patients in Canada, using FMT as a preventative method for immune-related colitis occurrence. We're waiting for its final results. And phase 3 studies are planned with CBM588 to test this compound's impact on clinical outcomes in a large setting. At this point in time, we do not have any sufficient evidence to give any suggestions about microbiome-directed strategies, but it is clear from preclinical and clinical evidence that these interventions will transition into later stages of clinical trials. At this point, it is important to review all considerations and select optimal strategies while planning these clinical studies. In the past, the studies enrolled patients from different cancer types, different cancer settings. This needs to be homogenized. Although we did not see any safety concerns in the past with these interventions, it is critical to ensure the rates of immune-related adverse events with the use of these interventions are being monitored, and there are pre-specified criteria for their discontinuation in the protocols. There will be a need for extensive data collection for diet, lifestyle, concomitant medication, supplements, probiotics, so that we could take into consideration all these potential confounders. And last but not least, manufacturability, patient preferences, social acceptance and ease of access for all patients are important considerations. Thank you.
Thank you, Dr. Desmond. Now it's my pleasure to introduce our next speaker, Dr. Tian Zhang, who is an associate professor at University of UT Southwestern, and she will be speaking about HIF-2 alpha inhibitors in patients with VHL disease and sporadic clear cell RCC.
Very good. Thank you, Dr. Tenier. Really appreciate the opportunity to talk about VHL syndrome and beyond and the development of HIF-2 alpha inhibitors. This story, I think, embodies a lot of what we have seen in progress in medicine from history of medicine and into both biochemistry and drug development. So I hope you're excited to hear about it as I am to give it. So we start from thinking about how we named von Hippel-Lindau syndrome. So back in the early 1900s, a German ophthalmologist, Eugene von Hippel, and a Swedish pathologist, Arvid Lindau, came together and they described these features of changes in blood vessel formation in the back of the eye and in the pancreas that we now know as von Hippel-Lindau syndrome. And clear cell kidney cancer is just one manifestation of this multi-system syndrome that affects multiple organ types. So retinal angiomas, hemangioblastomas of the cerebellum, pheochromocytomas of the adrenal glands, and pancreatic cysts are all complications of what we now know to be a germline loss of the VHL gene. We now know a ton about the oxygen sensing pathway and how the molecular mechanism of HIF and also, this one did not show, sorry, but how the oxygen sensing pathway occurs. So the HIF-alpha complex gets oxidized in normal oxygen conditions and binds the VHL protein, which acts as an E3 ligase to ubiquitinate and target the HIF-2 complex for degradation through the proteasome. In hypoxic conditions, the HIF complex dimerases, it's allowed to build up. There's not the hydroxylation, and the HIF complex dimerizes with HIF-1 beta, becomes a transcription factor as the dimer, and then allows the downstream erythropoiesis and tumorigenesis to occur. So in this context, both in germline loss of VHL as well as in sporadic clear cell kidney cancer, a defective VHL protein and loss of VHL affects this competitive activation. And this mimics the hypoxic conditions that then develops into angiogenic and tumorigenic mechanisms. So we now have multiple VEGF receptor targeted inhibitors that are now standard. You've been hearing about them through the day. And for a long time, it was thought that the HIF complex itself was not targetable. And over the course of time, we now understand the structure of the HIF complex, especially HIF-2 alpha. And there's this PAS-B domain. So what you see here is the structure of HIF-2 alpha in green, as well as an aryl hydrocarbon nuclear translocator in blue, which is also called HIF-1 beta. And this dimerization that occurs allows that translocation and the transcription activation in the cell. So what you see here is that interaction, and where they interact is this PAS-B domain that becomes very important when we're thinking about how to target HIF-2 and its dimerization. So when we're thinking about this, there was a large drug screening study done by Steve McKnight and his colleagues at UT Southwestern, which founded the first couple of molecules. The first one that we're showing here, termed PT2385. That small molecule that you see here pointed out interferes with the dimerization of HIF-2 alpha and HIF-1 beta. And so when we interfere with that and do not allow the dimerization, this allows HIF-2 to be targetable and for HIF-2 to break down. So we now have the next formulation of this called PT2977, which ultimately became belzutifan. We'll talk through the clinical development of belzutifan here. But you'll notice that in comparison to the initial PT2385 molecule, there's just a difference of the fluoride subgroups. And so this is also a very potent inhibitor inhibitor of that dimerization process. What we're showing here is the phase 1 study performed by Dr. Schwery and colleagues that showed that in a dose expansion in 55 patients with clear cell kidney cancer, many of these patients had regression and objective responses of their clear cell tumors. So here you see that a little bit more. There were 24% favorable risk disease in this patient cohort. The majority had received 3 or more treatments for clear cell kidney cancer, and the objective response rate was 25%, with another 54% of patients achieving stable disease. So a vast majority, as you see in the waterfall plot, having stable disease or better. Of the incidence of adverse events, I would just note that anemia is an on-target effect, as is hypoxia in this patient population, and both of these will improve with holding or with addition of erythropoietin. So LIGHTSPARK 004 was a specific study of belzutifan in the VHL syndrome population. These are all patients with germline alterations of VHL. 61 patients were enrolled, and all were treated with the belzutifan compound. And you'll see the baseline characteristics here. Many of these patients also had the extra-renal manifestations of VHL syndrome, including the pancreatic neuroendocrine tumors, the hemangioblastomas, and the retinal lesions. In their clear cell target renal tumors, we saw all patients have at least stability of disease or better, and 49% of these patients have partial responses. This figure is particularly notable. You'll see that the black line there denotes the time that patients started on belzutifan, and the prior, to the left of that black line, are all the surgical procedures that patients had had up to that point, and to the right, very few surgical procedures occurred after patients started on belzutifan. And this is the off-target or so of belzutifan effect on CNS hemangiomas on the left, and also pancreatic neuroendocrine tumors on the right, where you see most of these extrarenal manifestations also improving on belzutifan. And then these are the other tumors of belzutifan's effects. So again, where the darker green starts is where patients started belzutifan, and the extrarenal manifestations before and after. And so you see multiple patients having benefit, not only in their renal tumors, but also in the extrarenal disease. That prompted the combination treatment and study of belzutifan with cabozantinib, which was recently published. This was, and we want to highlight the cohort 2 of patients who had prior immunotherapy treatments. 50 patients in this cohort received the combination of belzutifan and cabozantinib. You see their baseline characteristics here, many of whom had received either IO or IO-VEGF combinations in the frontline setting. You see multiple people having 22% having partial responses, and another 68% having stable disease. So altogether, 90% or so of patients with stable disease or improved disease control. And these are the treatment-related adverse events. You'll see that many of these patients do receive, develop anemia. This is an on-target effect of belzutifan. There are multiple ongoing studies in refractory kidney cancer with belzutifan. There's a phase 3 of belzutifan versus everolimus in the refractory setting, a phase 2 dose comparing 2 doses of belzutifan, and then also belzutifan plus lenvatinib versus cabozantinib in the refractory setting. So all trials to keep an eye on that will result hopefully soon. There are also studies now, now that Peloton has been acquired by Merck, that belzutifan has been moved into earlier phases of disease and earlier disease settings of clear cell kidney cancer. We talked a bit about the LIGHTSPARK 012 trial yesterday in the first-line metastatic setting, building on lenvatinib with pembrolizumab. LIGHTSPARK 022 is an adjuvant study done in post-op patients randomized to either pembrolizumab alone or pembrolizumab with belzutifan. There are other HIF agents now in development, HIF inhibiting agents. So there are a couple of Nikon therapeutics as well as Novartis. This is not the most recent version of my slides, I apologize. And then also Arcus Biosciences. All of these inhibitors are currently in clinical development. And there's a silencing RNA as well that blocks the transcription of HIF2. Arrowhead has that in clinical development. So all molecules to keep an eye on. Of note, as we treat patients with HIF2 inhibitors, there are also multiple acquired resistance mechanisms. Here you see two mutations that were found to confer resistance to the PT2399 small molecule in the lab. Both one in the HIF1 beta protein and then also one in the HIF2 alpha protein can interfere with their dimerization and ability to bind these compounds. And so when you see that when patients are treated, this is a patient who was treated on one of the phase 1 studies that we had ongoing at UT Southwestern, that patient also over time develops these very exact mutations as an acquired mechanism of resistance to the Peloton agent. So take-home messages, HIF2 alpha certainly is now a targetable protein. Belzutifan is making a difference for our patients with VHL syndrome as well as in clear cell kidney cancer. Combinations of these HIF2 alpha inhibitors with other effective therapies will continue to affect the landscape of our treatment options, and resistance will start to impact our ability to think about patients who become resistant to HIF inhibition, and I think it poses another challenge in our field. And with that, I'll thank you very much for your attention.
Dr. Zhang. Now, I have the pleasure to introduce Dr. Thomas Paul from the Barts Cancer Institute in London, who ultimately changed the title of his talk, maybe because he found the challenge with the task that was given by the organizing committee. So now the new title is Horizon Scanning Clear Cell SCC in 12 minutes, excluding HIF and microbiome therapy.
I've got a number of conflicts of interest. My slide's not here. I'm very happy to discuss them afterwards. I'm not quite sure why I didn't include it. I apologize. I've got 12 minutes. There are different things I could talk about. I'm going to talk about some targets at the moment, but the second half I'm going to go a little bit off-piste, if I may, and I hope at the end I'm going to come back and I'm going to try and do it in now 9 minutes and 22 seconds. I think one of the biggest developments in the last year or two has been the positive data at AACR a couple of weeks ago. Personalized cancer vaccines, the RNA vaccines, have been actually around for a period of time, and in fact the COVID, as you know, the COVID vaccines, much of that development and the reason it was so quick to develop those vaccines is we've been using RNA vaccines for some period of time. The principle is relatively straightforward. They're personalized vaccines. You look for mutations within the tumor and you generate vaccines based off those. It takes some time to do that, and then they are reinfused. And the results to date hadn't been terrific, but there was this is the Moderna vaccine. There's a BioNTech vaccine as well, which I'm happy to talk about. But this data's in melanoma, and I thought it was really interesting. It's important because it's with pembrolizumab. It's also in the adjuvant setting. We've liked to develop drugs in the advanced metastatic setting. I think developing personalized vaccines in the advanced metastatic setting is really quite complicated because of tumor heterogeneity and the timing of the vaccination. I think it's easier in the adjuvant setting. We probably should have started there and not done these advanced disease trials. As you can see, the vast majority of patients you can make a vaccine. That's really important because the process is complicated, and you can see here the curves going apart in a randomized phase 2 study. My feeling is this will prompt a number of trials in different areas. As I said previously, we've actually done some work previously in advanced disease, and although it says lung cancer and breast cancer and colorectal cancer, there were renal cancer cohorts. We enrolled a whole lot of renal patients to this. They didn't respond to therapy. But again, this was in the late disease setting with all the potential shortcomings associated with vaccines there. I'm going to park that issue, but I think it's really important, and I hope we're going to investigate this more definitively in kidney cancer in the not too distant future. It's also reasonable to talk about LAG3, and again, there's melanoma data looking at LAG3. I'm not sure why we haven't launched SHIPs in kidney cancer yet regarding LAG3. I think it's an important target that deserves exploration, and I'm surprised we haven't seen more LAG3 randomized trials, randomized phase 2, not randomized phase 3, in this setting. And I think to some extent the same applies with TIGIT. I know there's controversy around this lung cancer data and TIGIT as a target. Nevertheless, I think it's justified to explore this in kidney cancer as well. And I've been, over a period of time, trying to get trials in these areas off the ground with mixed results, to be honest with you. There is a series of other targets which have been explored, and I think these were during the hubris of kidney cancer drug development, where we explored almost any target and we assumed it would have an immune component to it, and this includes adenosine inhibition. Actually, I'm not convinced this will see the light of day, and it's not the most promising target in my mind. And of course, the IL-2 issue is controversial, and Nizar is here with us. My personal feeling is that IL-2 doesn't have a future in kidney cancer. I know Dave McDermott disagrees with me on that issue. I'm intrigued by this curve, though, because I sort of like this curve because this is nivolumab versus sunitinib. And you can see the curves going apart and going back together. One might argue that is ipi-nivo, is the tail of the curve being generated by the CTLA-4. And I think that's perhaps the most provocative thing about these data. The other thing that I was really disappointed about these data, and this is maybe why I'm talking about it, is we never saw the good risk data. Wouldn't it be nice to see single-agent nivolumab in a randomized trial in good risk disease? I'm not sure if the patients were included, they just weren't included in the analysis. I'm disappointed by that. I think we should look at that data, and I'm going to speak to people and see if we can see that data. I think it's important, and it's going to get increasingly important because there's a study called 8Y8 kicking around there, ipi-nivo versus nivolumab. This surely is an important trial. I think we can all agree on that. 450 patients, not that many, 80 sites around the world, so one would imagine you could enroll that in under a year, 400 patients, 80 sites. Started in June 2019, so that's 4 years ago, and response rate is the primary endpoint. Of course, 18-week response rate. We should be seeing these data relatively soon, I would hope. On the clinicaltrials.gov, it says about April 2024. That feels like a long time, considering the PFS for Nivo is only 10 months, and the trial started 4 years ago. So I'm excited to see more data with IPI and Nivo by itself, which is out there. Glutaminase inhibition has had its day, I'm afraid. We did a randomized trial called the Cantata trial. Again, it was sold to us in a slightly complicated way. I'm not sure we ever got to the bottom of the specific mechanism in kidney cancer about why it would work here. It was combined with cabozantinib. My slides are moving by themselves, which is exciting. I hope that process continues to make my talk more complicated. The progression-free survival of cabozantinib plus placebo, which is the red, I want to keep your eye on. 9 months. Feels like quite a long time. Second-line PFS of 9 months. Remember, the axitinib trial was shorter than that, about 6 months. And some people have said, is this because prior immune therapy is giving subsequent VEGF-targeted therapy an immune boost? Immune therapy, back in the day, we said when we gave it, it would have long-term durable effects. And is it conceivable that giving first-line immune therapy results in a boost in second-line therapy? I've done a little bit of work on that, and this is the prior group. So again, placebo, cabozantinib in patients who received immune checkpoint inhibition previously. And here the progression-free survival is 9.2 months. In the entire population, it's 9.3. So it's fair to say in this trial, which is probably the most robust way of exploring that issue, it doesn't seem that prior immune therapy is associated with a boost. I spent some time making this slide over the last couple of weeks, exploring that issue in more detail. And you can see in the pre-IO era at the top and the PD-1 pre-treated era below, you can see a number of trials. And I think it's fair to say the response rates seem to have bounced since the PD-1 pre-treated era has come about. However, the progression-free and overall survival seems somewhat uncertain. And where am I going with this? Oh God, I'm going in the direction of CONTACT-3 Contract 3 is a randomized phase 3 trial of Cabo versus Cabo with Atezo. We know from a press release it's negative. We hope to see the data in the not too distant future. And I think this trial is going to be really important because at the moment we don't know how long we should be giving immune checkpoint inhibition for in the first line setting and whether or not we should be re-challenging subsequently. And I think what I'm beginning to suggest is this halo effect around immune therapy saying you give it and patients subsequently do much better. I'm not sure that's true, and here re-challenging with immune therapy doesn't seem to work either. So this hubris around immune therapy, this halo effect that we've been talking about, we need to think about very carefully over the next 12 to 24 months with the data that becomes available to us. So just as I inflate a tiny bit the immune therapy bubble, I move on to the IMDC classification, good, intermediate, and poor risk disease. I question how much this classification is helping us to predict response to immune therapy. We're clearly using it for good, intermediate, and poor risk disease, choosing Ipi/Nivo, which is a very important component of what we do. But actually, the good risk patients, the intermediate risk patients, and the poor risk patients actually have all subsets of these response criteria. So the angiogenic patients, I agree, are going to be more prominent in the good risk patients, but in the intermediate risk patients, there'll be a number of those as well. And of course, there'll probably be some CTLA-4 biomarkers. We're making no effort to identify which those patients are. And in this poor risk group, you can see mainly immunogenic, but there'll be some patients that we know who require immune therapy. And I put it to you as a group that we need to move away from this IMDC criteria and move towards taking tumors from patients, either circulating or baseline tumors, and designing studies off the biology of the disease in the knowledge that using this classification, while attractive on the one hand up to now, is probably not in its own right the future. Danny and I chatted about this, and certainly I think it has a role to play, but it should not be the only biomarker we ever develop in renal cancer. And there are indeed some studies which were described in the previous session. There's one in the US, there's one in Europe, and previously the Bionic study, which I have a lot of respect for. Just before I finish, and it looks like I'm overrun by 5 seconds already, so I'm going to be really quick. Really important issue. We know here are the various data cuts for CTLA-4, PD-L1, Ipi/Nivo with time. You can see the 70-month data point, hazard ratio of about 0.7. As we go back in time, the first data cut at 25 months, about 0.68. And then here I'm going to add a series of stars, and the stars are all of the data points we've ever had for the VEGF-TKI IO combinations. And you can see at the start of this journey with the shorter follow-up, the hazard ratios were lower than Ipi/Nivo. And you can see they're now in the same ballpark as Ipi/Nivo. And so for those people who say Ipi/Nivo's got the best long-term data, it has the best long-term data because we don't yet have that long-term data for the VEGF-TKI IO combinations. And we await that with interest because it's going to answer a few questions for us. Remember, Ipi/Nivo, the Nivo continued forever, where that wasn't the case with Pembro. So that's point number one. Point number two, CTLA-4. How important is CTLA-4? And of course, there's this issue around cross-trial comparisons, which is fundamentally flawed. So we've got an exciting time coming up over the next year to address this. And where I'm going with this is I'm not convinced we've got this right. Are we right to stop PD-1 inhibition and continue with VEGF-TKI? Have we got it completely wrong? And actually we should be stopping the VEGF-TKI therapy and continuing with PD-1. I'm beginning to think we've got it completely wrong. Quick bit about papillary renal cancer, personalized therapy with MET inhibition, savolitinib plus durvalumab, 53% response rate in patients with MET alterations. I think it's nice to bring personalized therapy into this rarer subgroup. We're chasing the biology of the disease, which is important, and this is a randomized phase 3 study exploring this question, which I think is a really important question. Wouldn't it be nice to have personalized therapy in this disease? Very quickly, in conclusion, I like the RNA vaccines. I think they're attractive. I think LAG3 and TIGIT require exploration. I think clear cell renal cancer, I think we have developed a plateau with the drugs that are available to us. I think there's refining required with VEGF-targeted therapy and immune checkpoint inhibition. I think we really don't know enough about these biomarkers, and I'm not convinced we're going in the right direction, and I'm keen we change that in the very near future. And I'm quite attracted to personalised therapy in papillary renal cancer. I hope you enjoyed your time in Scotland. Thank you very much for your attention.
Thank you, Dr. Pao. Now, it's a pleasure to introduce my colleague and friend, Dr. Sylvie Négrier, who is our last speaker, and her presentation is about management of patients with RCC and brain metastasis.
Thank you. Thank you for the organizing committee to invite me in this always rich and very interesting meeting. So we'll go back now to the day practice, I would say, with the patient with brain metastases, and we'll try to summarize the role of systemic therapy in this very challenging patient, target and immunotherapy. So this talk will cover an overview to give you an understanding of brain mets in RCC that remains a challenging situation for patient and physician. And I'll try to give you an overview of the effect of recent therapeutic change on this difficult clinical situation. And first of all, I think it's important to set up the landscape of this brain metastases in RCC, because we don't usually screen patients systematically for brain mets, and this is not commonly known. So it's very difficult to have an exact rate of brain mets in this patient, 8 to 12% at time of diagnosis of metastasis, according to analysis on more than 6,000 or 8,000 patients from the US database. But we know that 8 to 10% brain metastasis will occur later in the course of the disease, while autopsy series identify a 15% rate of brain mets in these patients. Asymptomatic lesions are most of the time not detected, and brain mets obviously is clearly underestimated. In terms of prognosis, as in other tumor types, brain mets from RCC patients are associated with a poor outcome, and the number of brain mets is one determinant of the prognosis, knowing that having multiple metastases reduces the hope of a long survival. And even in patients with asymptomatic brain metastasis incidentally diagnosed, they also have a poor outcome with usually a median overall survival around 1 year or less. And in this series, you can see results from different retrospective series with a median survival from 9 to 16 months. So, in summary, brain met is not a rare situation. 8 to 15% probably patients remain with a poor outcome, and patients with brain met were mostly excluded from major clinical trials due to the risk of neurological complication. And for this reason, prospective data and clinical trials are really lacking in the situation. What about the treatment? Local treatments, surgery, or stereotactic radiation remain the mainstay of treatment for brain metastases. But local treatments have a number of limitations. Some brain regions that are high risk of complication, like brainstem or motor function brain areas. The number of brain metastases can be very challenging, and survival finally can be compromised by other metastases, even in absence of progression of the brain metastases. So in terms of systemic treatment, we know that brain mets as a unique metastatic site is a rare situation. So most of the patients were proposed targeted therapies, and they were commonly used in these patients, but reports of TKI are mostly retrospective, and we have now limited data on the use of checkpoint inhibitor yet. So if we look at the target therapies, and I summarize here a series of more than 30 patients with pre-treated brain metastases. And as you can see, median overall survival are from 6 to 14 months in overall. There was a recent meta-analysis performed on almost 900 of patients with brain mets that were previously treated by local treatment with or without VEGFR TKIs. And this, the result of this analysis seemed to favor the combination of local treatment and TKI with an improved OS with 0.6 HR and an improved local brain mets control with an HR of 0.3. And there were no major neurological adverse events due to the combination of these two types of treatments. There are few reports of treatment with systemic therapy and target therapy without previous local treatment on brain mets. There was a very disappointing limited number of prospective trial done by the French group with no objective response, and more recently 2 retrospective series using cabozantinib that looks to indicate there may be an interesting treatment with an interesting response rate at least. So data are mostly retrospective and concern heterogeneous clinical situation with different treatments, so it's difficult to trigger any clear conclusion of the level of efficacy of target therapy on brain mets. However, VEGFR TKI seem to bring some benefit without compromising safety in patients with pre-treated brain metastases. So efficacy of TKI on brain met must be both prospectively and specifically investigated, and we hope that the French multi-center phase 2 CABRAMET trial, which completed the accrual, evaluating cabozantinib in non-pre-treated brain mets, should give some interesting results soon. So now, what about immunotherapy in patients with brain met from RCC? As you know, immunotherapy is now a large part of the standard treatments. But unfortunately, as you may know, randomized trial that led to the registration of these agents for the general population of RCC exclude patients with brain metastases, most of them, or only involve patients with previously treated and stable brain metastases. So for immunotherapy in patients with brain mets, we only have some retrospective studies. Most areas heterogeneous, speaking about RCC among other tumor types. Some patients with local treatment before immunotherapy or not, different systemic treatment lines, different treatment modalities. No really conclusion can be drawn from this data. We also have a couple of data from subgroup analysis from prospective trial. But of course, the sample size is limited. There were one series coming from the Nivoran French study. And in this study, there was 85 patients with brain mets. And in this small sample, the brain met response rates appear rather low with 12%. And the brain mets progression-free survival was also disappointing. And there was also a cohort of patients with brain mets in the Javelin trial, axitinib and avelumab trial. And as you can see, there were 23 patients treated by AV and AXI with a median PFS around 5 months, which is not very encouraging. There was also a non-interventional prospective study. There was the Italian EAP program with nivolumab, with also 32 patients with brain mets. We don't know how many patients was previously treated on their brain mets, with an overall response rate of 19% and 1 year overall survival of more than 66%. There was also EPI-NIVO trial, the Checkmate 920 on brain met patients, with 28 patients with brain met, but 25 of them were already pre-treated before the immunotherapy. In this patient, the overall response rate was 32%, with a 1 year overall survival of 85%. And finally, as you already heard this morning from Dr. Hang, there is the IMDC BM cohort, which studied patients treated with TKI and IO. This was prospective data and retrospective analysis, and on the whole cohort, there were 89 patients treated by IO. And in this patient, the median overall survival was of more than 32 months. So in conclusion, available data of immunotherapy in brain mets patients are very limited. Immunotherapy after local treatment, mainly radiation, does not induce dramatic increase of neurologic adverse events, but we have to be cautious for potential long-term effects. The level of efficacy in non-pretreated brain metastases is unknown today, so dedicated trials are really warranted for these patients. So in conclusion, screening for brain mets should be encouraged for these patients. Evidence-based level is low to determine the best therapeutic strategy. Local treatment followed by TKI seems to bring a benefit, and it's really too early to know the real effect of IO in this patient. So for this patient with brain mets that require an individual approach based on a multidisciplinary consensus, and we need also design and specific trial to help this patient in the future. Thank you for your attention.
Thank you, Dr. Négrier. I'd like to thank all our speakers for their wonderful presentations. I'm afraid we are really out of time, but Sylvie will allow maybe 2 burning questions, short questions, please, and short answers. Dr. Powell's short answers, please. Who would like to ask questions? Please come to the floor microphones. Dr. Lisa Hanskin. Okay.
I have a question for Tian. I'm wondering if belzutifan is really more effective in patients who have von Hippel-Lindau disease versus sporadic renal cell carcinoma, or if it's just that we haven't really tried it as the frontline treatment in.
Oh, it's a great question, Lisa. Thanks for it. I think those with VHL loss, so because VHL syndrome patients have germline loss, they're exquisitely sensitive to this pathway. Patients with sporadic clear cell kidney cancer that do have loss of VHL, which is the vast majority of them, they will be sensitive. We just haven't used belzutifan quite yet in the frontline setting, but I'm looking forward to the frontline trials.
Dr. Atkins?
Yes, hi. Tom, you proposed stopping the TKI and the IO-TKI combinations and continuing with IO. Is there any even anecdotal data that supports that approach?
It's a difficult question, Mike, and I'll be very, very quick because I'm under a degree of pressure. One could argue the STAR study, which looked at intermittent versus continuous VEGF-TKI therapy in the pre-IO era with 1,100 patients, addresses that to some extent. I think that showed no real difference in overall survival, although by the letter of the law it didn't hit non-inferiority. The Kaplan-Meier curves are largely overlapping. I think that justifies exploring it. I'm also quite concerned that VEGF, I listened to your talk with interest. I was also intrigued about, I've seen people present the hypothesis that immune infiltrate might result in synergistic interactions between VEGF-TKI and IO therapy. You talked about some of the potential inhibition between those two. And I think that particularly at the beginning of the disease process, I can see why the combination is really attractive. But I think we all have patients who have been on VEGF-TKI therapy for years and years who want to stop it, who we want to stop it, and I think it's reasonable to explore that. Whether it's 2 years, 1 year, 6 months, I'm not sure. My feeling is 6 months is too short and 5 years is too long.
Thank you. I'm sorry, but it's whole time for questions. So I thank you, all the faculty.